I'm really glad to be able to be hosting this this event about the importance of biomedical engineering in advancing European Union health priorities. So first, I will give some short opening remarks, and then we will continue with the rest of the panelists. First, I would like to introduce myself. My name is Tomislav Sokol. I'm the member of European Parliament, member of the ENVI Committee on Environment, Public Health and Food Safety. I'm also the member of the new specially established Committee on COVID-19, learning from the purpose of which is the learning from the experience of the COVID-19 to prevent something like this from happening in the future. And I'm glad that I'll be able to say something about European Union health policy and its priorities. So first, what I would like to emphasize when we speak of European Union health policy and priorities is the fact that traditionally healthcare has been a marginal topic within the ambit of European Union institutions and European Union actions. This has the reason for this that was usually stated was the fact that according to the European Union founding treaties, healthcare was primarily a national competence, and we have concrete provisions in the European Union Treaty on the Functioning of the EU, Article 168, which says that financing and organization of healthcare systems is a national priority. However, it is the fact that the fact is that despite of this kind of division of competences, European Union has a lot of regulatory and financial possibilities to advance certain health priorities and to influence member states' actions in the area of healthcare and to be able to achieve better health outcomes and better results of healthcare systems. However, this political atmosphere, which used this division of competences as an alibi not to do a lot in the area of healthcare on EU level, has changed. Of course, the main reason for this has been the COVID-19 pandemic, but also apart from that, the initiative which was started by European People's Party, of which I'm a member of, and that is the creation of the Europe's Beating Cancer Plan and the making the beating cancer and fighting cancer one of the European Union policy priorities. So this whole situation with the cancer and of course with COVID-19 pandemic has really changed the overall atmosphere in the European Union in terms of healthcare. So healthcare has really become one of the main topics of discussions on the European Union level. So when we speak of priorities, and advancing European Union health priorities in the area of healthcare, the first question obviously is to define what is So we don't have one strategic document determining all healthcare priorities of European Union. However, when we speak of the priorities, I believe that we have a lot of sources by now which define actually what European Union wants to do in the area of healthcare. So I think the first priority that we can discuss in terms of healthcare on EU level is preparedness for future crises. So COVID-19 has shown us that the European Union member states and the European Union as a whole were not really prepared for such a pandemic, for such a public health crisis that happened. And definitely the main priority in the future will be to create a much better system of preparedness, of early response, and of monitoring and early warning of pandemics, if such pandemics occur in the future. And of course, the main actions that have been already undertaken included the creation of HERA, strengthening of the ECDC, EMA, and all the other European Union agencies which deal with healthcare. The second important priority that can be, I believe, highlighted is in the area of cancer. So we have Europe's Beating Cancer Plan. We have the European Parliament's report on beating cancer, which I contributed to as the BECA committee, Special Committee on Beating Cancer. And I believe that beating cancer as the second cause of death in European Union definitely will be something that will be very important for the European Union in the years to come. When we speak of beating cancer, what is important is that this plan covers all phases of beating cancer, which means starting from prevention, early detection, treatment, but also survivorship and taking care of people who survived cancer. And what I believe, however, that the main topic here, but the main topic in general should be, and this is something that I'm also advocating in the European Parliament, is the problem of equality of access. So the quality and the access to healthcare, quality of healthcare provision, and standards of healthcare provision across the European Union are not the same. So there are very big differences in terms of health outcomes, in terms of prevalence of certain diseases, in terms of surviving certain diseases. For instance, there are 30 to 40% bigger chances of dying from cancer if you were born in some regions of Eastern Europe than in Western or Northern Europe. So I believe that using EU tools to facilitate equal access to healthcare, to create a level playing field in terms of increasing standards and the quality of healthcare across the European Union, to have more or less equal or similar standards, will be one of the main priorities of the EU, and this is something that is really being discussed a lot at the moment. And the one final point that I would also like to mention here when we discuss priority is autonomy. So the necessity for European Union not to be dependent on production of certain medical devices, medical products, of certain ingredients, of certain medical products from other countries. Because we see also from the experience of the Ukraine conflict and Russian aggression on Ukraine, that being dependent on third players, third countries like China, Russia, whatever, is very dangerous. Because in case of a crisis, be it war, pandemic, or something else, definitely such sources of supply become very risky. So it becomes very questionable whether European Union is able to secure these necessary resources from such third countries, which means that we have to think on the European Union level about what to do to increase our strategic autonomy, that we are not so dependent on other countries, on other players, on production from other parts of the world. And this is something that has been highlighted in the European Union pharmaceutical strategy, which specifically emphasizes this point. So these I believe are the most important European Union health priorities. So what can we do in terms of biomedical engineering? I think that biomedical engineering has a very important role to play as research and innovation in the area of healthcare in general. So healthcare costs are rising. Our life expectancy is much longer and longer, which is definitely a good thing. But this obviously creates new health needs, new needs of the healthcare systems, and the only way to tackle this is through research and innovation. So I believe that what the European Union has to do is to create a framework, an ecosystem where research and innovation will be facilitated and not hampered by too much bureaucracy, too much administration, too much unnecessary regulation, and all the other things that the European Union is unfortunately very well known for. So what are these instruments? So what I would like to mention, obviously, we have the medical devices regulation, which was adopted 5 years ago. I think it is very important, but of course we have to see how it will be implemented also in the future, and to use this to determine whether any changes are needed. The second point that I would like to make, the second very important piece of legislation that was recently adopted, is the regulation on health technology assessment. This health technology assessment regulation is very important because its primary purpose was to create one-stop shop, let's say, so that innovators, that companies which create new medical technologies do not have to go through 27 different regulatory processes of approving new medical technologies in their healthcare systems. So to have one European system instead of having having to undergo 27 different national procedures. Unfortunately, after long negotiations with the Council, the final result is a compromise which I believe falls short of this objective that I mentioned. Why? Because according to the final version that was adopted, this this regulation only when prescribing obligations on part of the member states, it only says that member states have to take into account the results of the health technology assessment on European level, which means they can do it, but they do not have to do it. And of course, such a system really does not contribute to legal certainty and allows member states to still have their own national different policies and procedures when introducing new health technologies to their healthcare systems. Also, this HTA regulation does not cover reimbursement of new medical technologies, meaning the procedures for determining whether a new medical technologies will be financed by national healthcare system of a member state. And this is very unfortunate because the only piece of legislation which we currently have which regulates this is the so-called Transparency Directive from 1989, which is outdated and definitely not fit for its purpose. So what I believe that further legislative steps and revision of this legal framework is necessary so that we facilitate introduction of new medical technologies into healthcare systems, but not just putting them on the market, but actually making decisions about reimbursement from national health insurance funds. Because the big majority of healthcare spending in the EU is from the national health insurance funds of the member states, and still in this area still enormous differences exist, different national policies, different national priorities, different national procedures in determining whether to adopt new health technologies into their national social security healthcare packages. And this situation, this is, I believe, not sustainable in the long run. So that was about the most important regulatory framework. What I would also like to mention is the financial framework. So EU also has a lot of financing at its disposal to facilitate introduction of new technologies, including results of biomedical engineering into healthcare systems. Of course, the most important legal financial instrument in that regard is Horizon. So the new Horizon for the next budgetary period, one of the clusters of Horizon is devoted to health, and also one of the priority missions is beating cancer, which means that healthcare now will become one of the policy priorities in terms of funding from Horizon. And I believe that this also creates new opportunities to develop new projects funded from the EU in the area of biomedical engineering as well. There is also the EU for Health program, the new budgetary program of the European Union, which is 12 times bigger than previous budgetary program in the previous budgetary period 2014 to 2020. So now for the period until 2027, we have 5.3 billion euros at our disposal. Most of this money will probably be allocated to HERA and for creating for strengthening responsiveness and preparedness for future crises. But I hope that also at least part of it can be also devoted to research, to introduction of new technologies, biomedical engineering included. And the last point, which is also important as a spending source, is cohesion policy. You know that cohesion policy is the main financial instrument to reduce inequalities in European Union, inequalities in terms of the level of economic and social development. And a lot of this money has also been allocated to healthcare. Around 25 billion euros was allocated to healthcare from cohesion policy for the period 2014 to 2020. So since we now have even more money at our disposal for the next budgetary period, I believe that a lot of this funding should also be used to stimulate research, top quality research and innovation in the member states, especially creating, funding the necessary equipment and the personnel and workforce, which is necessary to conduct research in all the member states. And I believe that European Union can also do a lot in terms of promoting new technologies and new advancements in biomedical engineering as well. So to sum up, I think this is an important event. This event highlights the need and the priority that we have to give to new technologies, to innovation in the area of healthcare. I believe this is the only way if we want to improve our health outcomes and create better healthcare systems for our patients and for our citizens. I believe, despite this division of competences, that the European Union has a lot of instruments at its disposal now to do this, and I'm looking forward to working together with you, with all the stakeholders, to making European Health Union a reality and making European Union much more important in the area of healthcare than it currently is. So thank you very much again, and I look forward to hearing the other speakers.
Thank you so much, Mr. Sokol. It is really a great honor to be here, and I'm really grateful to you for accepting to organize such an important event that I hope will pave the way to dedicated events on specific topics. You mentioned so many things that are really important to us, and allow me to say that it seems I was under the impression of listening a professor of biomedical engineering when you were giving your welcome address, because you touch based on so many crucial points on which we really are advocating for since many years now. So if you allow me, I prepared a couple of slides to give a very brief visual introduction and then leave the floor to the speakers today. I am Leandro Pecchia, I'm a professor of biomedical engineering, and I am coordinating this part of the session as president of the European Society of Biomedical Engineering. Now, when normally I teach to my students, I start asking them if they have a feeling of how much medicine has been changing in the past hundreds or 200 years. And if you accept those two pictures on the left as an exemplar of medicine starting in the start of former century and how it is done today, to be honest, I really don't see many differences. I mean, we still have here a doctor in the center with the patient, which is certainly the most important part of the scene, plus the clinicians or the nurses around them. The only thing which really changed is the environment in which this has happened. So we do that. We change the environment in which medical doctors and patients act together in order to improve quality of life. That's exactly the work of biomedical engineers. And whenever I want to give a proxy for how fast this is growing or how fast this is going to grow in future, I take those data which come from MedTech Europe about number of patent applications in Europe. And the line here says that patents applications for medical device since 2016 overcome the number of 12,000 novel patent applications per year, which is more than you can expect from drugs or biomedical or biotechnologies, for instance. And that's a huge number because 12,000 per year means more than 1,000 per month, which means basically if you count 20 working days in Europe, this means 50 novel patent applications per day, which if you count 10 working hours in Europe from the very eastern part to the very western part, this means that by the time we end this meeting today, 1 hour and a half, you will have had 7-10 novel patent applications filed in Europe, which is a huge number. Obviously, they will not all become medical devices, but that's still a huge number. And thanks to the work that biomedical engineers are doing, well, they have also been very well recognized by international policymakers. I just put on this slide World Health Organization statement that more biomedical engineers and well-trained ones are needed for design, regulation, maintenance, management, and assessment of medical device. We heard from Mr. Sokol the importance of health technology assessment for Europe. And the European institutions are also starting recognizing this profession. Just to mention this document that Reporter Edgardo Iozia coordinated the writing for the European Economic and Social Committee, which was stating that biomedical engineering is not a subset of modern medicine. It is actually modern medicine, which is achieving the great goal they are achieving because of our output, which are medical devices. And just before I conclude, I just took an exemplar of medical device to share with you this reflection on how much just one key technology, medical ventilator, has been evolved since the last few decades. So if we started in the start of last century with something as the one you have on the left, and we arrived today with the most advanced possible technologies, which we all have seen deeply important for disease in Europe, coronavirus disease in Europe. Yet there are areas where we can do much more together. We need to learn how to really prioritize those needs which are crucial for the European population and beyond. Don't forget that Europe, when it comes to biomedical engineering, accounts for about 40% of the global population of biomedical engineering. So all the innovation we bring in Europe then arrives and benefit all the patients all over the world. And there are still areas where we have to learn to do better. For instance, I put on this slide personal protective equipment because we are now facing still this pandemic, and those are essential health technologies for public health and infection prevention and control. And if you look on how those technologies evolved in the last 1,000 of years, 700 years, things are really bad, I would say. And while for medical device, Europe is leading, for those items which are as essential as important medical devices, we are dependent from other regions, as Mr. Sokol said. So we need to learn how to better spend money in Europe, because we are aware that a lot of money has been invested in research in the past few years. Now, the next thing we can do together is eventually to ensure that those money are spent really based on needs of patients and those coming from the global health perspective. And those are just tangible technologies. If I think to untangible technologies, if I think to AI, European data space, all the technology we need in order to collect and manage safely patient data, then that's another area where probably we can further support Europe and together the global community to do better. Now, I would ask Professor Timo Jamsa, former president of the European Society of Biomedical Engineering, to share his screen and give us a quick introduction on EAMBES. Timo, the floor is yours. Thank you.
So, thank you very much, Leandro. And it says that I cannot share while you are sharing still. So, let's try to do it again. I guess you can see now my presentation. Okay, thank you very much. It's a great pleasure to be here today, even if not face to face. And great to have so many connected. So, I'm Timo Jamsa. I'm from University of Oulu, Finland, and past president of EAMBES. And I will have a quite short presentation on EAMBES. We are a community representing biomedical engineering in Europe. And non-profit organization representing most of the scientific societies in the domain, and also several institutions, and quite a nice number of more than 100 distinguished fellows representing the key experts in the field. We are not alone as EAMBES, but we are a part of the European, beyond Europe, the global biomedical engineering community. EAMBES is member of IFMP, that is the International Federation of Medical and Biological Engineering, that is jointly with the medical physicists represented in the International Science Council. And via IFMP, we have also an official relation with WHO that has been very valuable, for instance, in these times with COVID-19. And we have some priorities that we would like to collaborate with the EU Parliament. We have done that, and we will want to do that also in future, related to patient safety, sustainability of healthcare, support manufacturing of medical devices, the creation of the European data space. And practically, we are willing to support when preparing new directives that are related to health technologies. And of course, in the current topic, AI and digital health are very, very up-to-date issues here, as already Leandro mentioned. And also to blueprint the future research initiatives. And EAMBES is also willing to support United Nations for the Sustainable Development Goals. And I would like to shortly give just a few examples of, I would say, great examples on how we are working as biomedical engineers for the community. So Professor Maria Chiara Carroccia, one of EAMBES fellows, she was recently appointed as president of the Italian National Research Council. He is one of the leading experts in biorobotics, biomechatronics, neuroengineering, rehabilitation, very important areas in biomedical engineering, and also former Italian Minister of Education, Universities and Research. Professor Magdalena Stoeva, she is editor-in-chief of the EAMBES journal, Health and Technology, and she has been very strongly leading topical collection of biomedical engineering contributions to the COVID-19 response. And there has been a special focus for low and middle income countries where the support is really needed. And Dr. Kalirois Stavrinau, technical manager of EAMBES, she has strongly supported the collaboration with WHO, especially organizing a great series of webinars, sharing knowledge, success stories among clinical engineers during this pandemic. And more than 20 webinars have been organized with more than 100 speakers from more than 50 countries, reaching more than 1,000 attendees worldwide. Great contribution. And many EAMBES community members have been working actively to strengthening the response to COVID-19 and beyond, in very close collaboration with WHO. One special mentioning to highlight Professor Dan Clark, and who has been awarded recently with an Officer of the Order of the British Empire by Her Majesty of Queen on the services in clinical engineering, especially related COVID-19. Here we are now in European Parliament Interest Group on Biomedical Engineering that was established in 2016. The first meeting was held in Brussels in 2016 in collaboration with IFMP, with IUPSM, with World WHO and MedTech Europe. And the topics highlighted were recognition, regulation, representation, harmonization, and research related to biomedical engineering. The second meeting was held in 2018 in Brussels. And in the second meeting, we also included cooperation with Africa as a very important field to be responded now and in future. So, EAMBES is willing to continue supporting the European Parliament and Commission for the current and future health policies, with some points for discussion. The regulations of medical devices, personal protective equipment, and artificial intelligence. To raise the attention on emerging challenges. To contribute to the focus on European research and innovation investments for acute and important needs like aging, cardiovascular diseases, cancer, and so on. And to foster the creation of the EU data space, enabling the growth of EU AI for health. Thank you.
Thank you, Timo. Thank you very much for your presentation. We can move now to the panel session. Adriana Velasquez from the World Health Organization, she is busy in another meeting. She will join as soon as possible. So allow me to introduce Professor Shankar Krishnan.
I am here, Leandro.
Oh, Adriana, sorry, I could not see you. Then the floor is yours. Adriana, thank you for joining. Feel free to turn on your camera if you can. And I leave you the floor. Oh, thank you so much. Adriana Velasquez, she's the focal point for the World Health Organization, senior advisor and expert for medical device and also in vitro diagnostic. She has been leading several activities in the WHO in the area of medical device after establishing in Mexico the National Center for Health Technology Excellence to Cenetech in 2021. And she's the founder of the World Health Organization Global Forum on Medical Device, where really we managed to bring together people, different stakeholders, to discuss together how to enhance patient quality of life also with medical device. Adriana, the floor is yours. Thank you for joining.
Thank you very much, Leandro. I don't know if you can see my screen.
Yes, we can.
Perfect. Thank you very much. First of all, thank you very much for inviting me to this session. As referred before, yes, this is not the first time that I participate in these ethics sessions, and so thank you for the invitation. My presentation leads on the global crisis, preparedness for, and the role of biomedical engineering. So I'll just keep it very short, but it is about the link between biomedical engineers and medical devices, our roles in peace times and our roles in global crises, and which are our main challenges. As you all know, we really need medical devices. Everyone, everywhere needs medical devices for protection, diagnostic, treatment, monitoring, rehabilitation, and so on. But we need to ensure that they are safe, good quality, affordable, available, accessible, and acceptable. And this is exactly the role of the biomedical engineers. We have to be involved in all these aspects. And the aspects will include the innovation, the regulation, the selection or HTA, and then health technology management. But for all of them, we need to have a nomenclature that can help us guide all the work that we do in the different instances. Our goal is to ensure improved access to safe, good quality, affordable, appropriate, acceptable medical devices, as I mentioned before. And we deal with all types of medical devices. Sometimes as biomedical engineers, we just talk about medical equipment, but no, we have to be involved in PPE, as Leandro was talking about, medical software, surgical instruments, implantable, even in vitro diagnostics. WHO has 3 billion targets, and we were working for universal health coverage when all of a sudden COVID struck, and then we were now working on the 1 billion to get people more protected. So then we needed PPE, we needed the diagnostics, we needed all the equipment that we need in intensive care units to test, treat patients, and protect healthcare workers. We did this like in a super fast time. It was 100 technical specifications and the list for medical devices. We need priority medical devices for COVID-19 and their technical specifications, like maybe 6 months. So it was like a record time, and the book was published, and it links to all the interventions and all the technical specifications. Along with our colleagues from IPC and personal protective equipment, we developed this new publication that was also in a record time, and that was helped by our technical advisory group that was developed also in record time, and we developed these ones in November. So all of these books, and they have all the listings, they were added to other existing documents that we had in WHO for HTA regulations, equipment and management, etc. So now they're part of the technical series. We also use these specifications to be able to do the supply portal that was WHO procuring for 170 member states, all kinds of medical devices and PPE and diagnostics. But also those lists could serve the member states so that the member states can take those lists, compare it with the things that they need and they have, so the local needs, epidemiology, have a prioritized list, and then be able to put these devices into the primary, second, or specialized care services. For all of this work, we require, and it is indispensable to have biomedical engineers that can understand the technologies, can understand the needs, and can understand the use of it. We also launched the Compendium of Innovative Technologies that was urgent to be made to find more technologies that would be to help address COVID issues. So that includes the revision of the technology, how much it was needed, the regulatory, the health technology assessment, the market, the intellectual property, the affordability. And then this was published also in record time last year. And then we are republishing the second version of this in a few months. And we took from some of these technologies, and we're inviting them to join the technology access pool to see if there could be the possibility that some of these technologies could be locally produced in some countries. And for that, we're also requesting biomedical engineering experts to help us. But the big challenge that we have, and we're also asking biomedical engineers, and we're asking all of you to please help us, is that the world does not have an international standardized nomenclature. We already did a pilot project last year. We're considering information from Europe, information from the US, information, we did a mapping. We have different tools in WHO like MEDEVIS, that's the Medical Device Information System, and the ICD, and we are trying to put the codes in there. Why is this important? Because you remember I told you this was the backbone, so the nomenclature can help us procure, can help the supply, can help the regulation, can help the assessment. So we are taking information from the EUDAMED, from the European database, and also the FDA to try to do this kind of harmonization. But the idea is to take this information from these public systems and then add them into WHO, into the MEDEVIS, UHCC, Universal Health Coverage Compendium, and have digital interoperability so that then countries can use it. But this is our main challenge, and this is being discussed in the World Health Assembly, in the Executive Board, and will be discussed by member states this Thursday, and then back in May in the Assembly. So this is really our highest priority now, that will allow that anything that we have on the books, on publications, or in the platforms can have a code and a link that we could all use together towards inputting information from the books or from any other sources to make sure that we have a good advance. And in conclusion, biomedical engineers need to be part and member of the health workforce. We need the technical knowledge, the passion, transparency in our work, and work together with many other healthcare workers. With that, I finish. Thank you very much.
Thank you, Adriana. Thank you very much. First of all, to accept this invitation. We know how busy you are, especially during this emergency, and your talks are really inspiring for our community, and I think also relevant message for our host at the European Parliament and to the European Commission. Thank you, Adriana, very much for that. I welcome now Professor Krishnan, that will co-chair with me the remaining part of this meeting. Krishnan is the president of the International Federation of Medical and Biological Engineering, IFMB, which is our mothership as EAMBES. And Krishnan, as you would never say, but more than 35 years of experience in the domain of biomedical engineering, has been working over 4 continents so far, educating students as a consultant, as an expert for manufacturers, but also for ministries of health all over the world. Krishnan, thank you for accepting this invitation. The floor is yours now for continuing this session, and probably you may have a few questions for our panelists and Adriana, first of all. Thank you, Krishnan.
Well, Professor Piquia, it is indeed my pleasure and honor to be here. I'm delighted to say that I had the pleasure of attending the 2 previous sessions, and I'm glad our friend Timo Hamsa showed the picture, and I see that I'm there, except, it is a few years ago, and we need to start working on anti-aging like most of the panelists are. I'm going in the other direction. But anyway, I must thank Dr. Adriana Velasquez for this fantastic presentation. She's been doing fabulous work Is she still here? I have a question for her. Oh, I must thank you for not only the presentation, the fabulous work, and we do this World Medical Devices, Global Medical Devices Forum, and we are very happy to participate. And, you are spearheading this important initiative. These publications are excellent. I hope people make use of all this. I just have a simple, you covered so many things, I think I must also say that I particularly enjoyed this presentation by the distinguished member of the Parliament. His talk was excellent. I think I need to digest it. It takes more time. After I have breakfast, I can digest better. My neurons will work better. So, Dr. Adriana Velasquez, the global pandemic highlighted many of the shortcomings of the health systems across the world. Whoever expected this, right? What lessons can we learn from these last couple of years, which are not the great years, on integrating advanced technologies and new approaches to strengthen our hand in future crises? If you can just comment briefly on that, I'll appreciate it.
Thank you, Professor Shankar, and really it's a pleasure to see you again. And thank you for the question. So, well, actually, what it really shows are that the most basic essential tools need to be available absolutely everywhere. And one of them was personal protective equipment. The second one is oxygen. Everybody takes for granted oxygen, and oxygen was a huge need. And maybe you remember that I've been saying about the need for oxygen for pneumonia and detection for pneumonia for long years. This pandemic really shows that those basic things need to be available absolutely everywhere. But it also raised the issue of the need of biomedical engineers, which it is very bad that we have to have a crisis to be recognized. But yes, they recognize that the medicines could not save the persons. We needed to save healthcare workers through protective equipment, but we needed to save patients through ventilators, ICU, and also have even computer-aided diagnostics to diagnose for the radiologists for their words. No, so I think bringing innovative technologies that could be more affordable and easier to use and good maintenance, it's really a game changer. And we look forward to having many more innovations really to address the needs of the people that are in the low resource settings. But looking forward to working with all of you.
Thanks very much for this excellent response. Professor Pecchia, you have a question for
Adriana, thank you so much. You mentioned medical device, you mentioned personal protective equipment. But what about the data? We saw with this pandemic that data sharing is really crucial in order to increase our preparedness, learn lessons, do better in future, respond better. What you would like to say to Mr. Sokol, to the European Parliament, to the European Commission about the importance of data in healthcare?
Thank you, Professor Pecchia. It is absolutely indispensable because we couldn't even know what was missing because there was not enough information. So how many do you need of X or Y devices? Well, the facility assessments were not there. Their inventories were done in different systems. And that is why we talk about the nomenclature and the harmonization. We need systems that could bring us the data and the information to make better decisions and to make sure that where are the needs and how can we better fill the gaps. But we didn't have enough information. How many equipment are working? How many are needed? Where do we need them? If they're functioning or not? How much do they cost? Prices are totally unknown. The issue about the beginning of the crisis, we didn't even have manufacturers to supply information. And they said, well, how many you need of this or that? And we just estimated. And that was the big issue. Right now, even for oxygen supply and everything related to ventilators and so, we're asking, please give us number, please give us information. So I think data and information is absolutely essential to drive a good response, a good preparedness for everything. Data also on the use of the devices and the use of the PPE. Are they reaching the last mile? because there was a lot of procurement done, and you remember those things, but is it really meeting the needs of the users or not? So yes, Leandro, I totally agree. Data is indispensable. And one core element of this data is that nomenclature that will help us at least put a single way of addressing all types of medical devices. So thank you.
Thank you, Adriano. Thank you very much. Professor Krishnan, back to you.
Thank you, Adriana. Thanks very much for your, continue your fantastic work, and we give you all the support. So we now go on to the panel discussion. We have a series of excellent speakers. We start with Professor Maria Teresa Arendelle. She's the first female electrical engineer at the Universidad Nacional de Tucumán, Argentina, later founder of the Argentinian Society of Biomedical Engineering. She's the first female to become full professor of telecommunication and bioengineering in Spain, professor at Bioengineering and Photonics Department at Universidad Politécnica de Madrid, UPM, and the director of the Latin American Affairs at UPM, and the director of Vodafone Chair for Healthcare and E-Inclusion since 2002. And I've had the pleasure of listening to Professor Maria Teresa in several countries. She's always giving a really exciting talk. So we look forward to hearing your thoughts on this topic. Professor Maria Teresa.
Thank you very much indeed, dear Krishnan. And thank you very much for inviting me to share our thought regarding how should be the investment for the citizen of the future in this new world. Thank you to Mr. Sokol from the European Parliament for helping us to support this making decisions in order to implement the procedures for the healthcare technology acquisition. I have to say that we are trying to support the investment of for the citizen of the future. I don't know what happens with my screen, but because we are facing a new era that should stimulate our research, and I can say that our biomedical engineers are ready to afford this challenge. Which is this challenge? We have a historical challenge in order to produce the impact on the city of the future and on the citizen of the future, which means that we have to support the hospital of the future of the healthcare, and the treatment of the future. And what is this about? The city of the future is composed by, should be and will be composed by smart and friendly environments, which will try to establish an intergenerational connection in these sustainable spaces for the citizens of the future, in which we have to deploy the assistance and the health services based in the technologies we have been mentioned during all these presentations previous to me. And we have to implement the public health care for the future, based mainly in the decision making based on the evidence and data with better information for and with the citizen. And in this context, this paradigm should implement the treatment for the future in which the smart systems are supporting us for making personalized decisions, optimizing the management and the empowerment of the patient. In the context of this general paradigm, the hospital of the future that should be mainly ubiquitous service for all the citizens, we will integrate the next generation technologies, the data and artificial intelligence, and we have to optimize these information flows between the patient and the healthcare world. And all of this should be based in some kind of digital technologies and data, such as artificial intelligence, cloud computing, the mobile health, all the wearables that will support the telemedicine services. And to do that, we have to use these tools given by the artificial intelligence, the Internet of Things paradigm, the robotics, the big data, and the 5G, to reduce the variability of the results and to improve them in order to produce a real impact in the society. This is impossible to be done without the involvement of the decision makers in the management of healthcare and mainly of the purchase of the technology. And this is the reason why in this talk, I would like to push the concept of the investment in digital technologies, in the new technologies, in order to provide a better health service. And what is the healthcare in this hyper-connected and new hyper-connected society? This should be something like humanized technology, because in the last years, we have been living in this pandemic in which we know that we have to have an integrative philosophy in the healthcare centered in the personal health ecosystem, providing a positive and smart health in the context of this humanized technology. Based in 6 design principles, which are the interoperability, the virtualization, decentralization, real-time capability, service-oriented, and modularity of the services. And all of these concepts should be around digital technologies like artificial intelligence, high-performance network for remote hospital assistance, and supporting the digital transformation in this healthcare process, the interoperability, the platforms and data spaces, the ubiquitous hospital, which is a very, very new concept, and supported by, as the previous person talked about, the smart pharmacy and concepts like an integrated robotics to provide the services, the operating room of the future with robots, augmented reality, and proactive intelligent controls to provide this ubiquitous personal healthcare space. And all of this is based in concepts like a data center, a cloud of services, a new modular hospital, a new space that is all around you, all around the user, and basically a new way of thinking. And this wants to be some pioneers' ideas for a better world. I have to say that the biomedical engineers in Europe are prepared to open the hands for this new work, and we trust in all the actions previously given by Dr. Sokol in his presentation regarding the involvement of the European Parliament to implement procedures for this healthcare technology acquisition, to support this new regulatory framework to make easier this implementation, to implement all these procedures. So everything is in our hands. Everything is in your hands. Let us work for a better world. Thank you very much.
Thank you, Professor Maria Teresa, for this fantastic presentation. You have been the first female engineer and accomplished so much, and I think you will be a great role model for all the future biomedical engineers, not only in Europe and Latin America, but all over the world. So keep continuing your work. I know you have also been doing a lot of work in assessment of Parkinson's disease and cognitive rehabilitation of stroke patients. remote management of diabetic patients and mental care, which is very important, which became after the COVID crisis. The city of the future and the hospital of the future, it is really good for biomedical engineers to start thinking big. We talk about all these modules they cover in education, but it is good to think about the ubiquitous hospital. And these ideas, I think, with the young innovators, which the distinguished member of the parliament also talked and you referred to, fit in very well with the frame. I have a question for you. I mean, particularly with respect to telemedicine, you talked about IoT and IoMT and so on. So telemedicine has been around for many years, However, just now during the pandemic, it seems like this got highlighted and got greater importance. And it also, you have been working in remote healthcare, but now everybody understands what is telemedicine, teleconsulting. So how do you foresee the evolution of this field, and what role do you see for biomedical engineers at the present and future?
Thank you very much for your words and for your comments, dear Krishna. Okay, I think that it's a reality that telemedicine now is a new tool in order to be communicated, and this will not go back to the past, so the progress of telemedicine is very clear. And then I envisage a very special field in which telemedicine is a big and huge and great support. And it is in the field of mental health. During the pandemic, we have been asked for different actors in different countries regarding the support of the medical actors in this pandemic, which were strongly affected by this problem, and also by the suffering of all the people that were affected by this disease. So we have been trying to implement services of supporting the mental health of the people that were involved in that. And this was proven to be extremely efficient in support the people through different tools, not only video conferences, not only the support of the experts, the remote experts on that, but also through different elements like the physical exercise, physical activities, the food intake, and also some other psychological supports to afford the challenges. This is one of the fields in which I think that the telemedicine had a big advance and will have in the future. But then in all the fields of the medical care, mainly for chronic patients like neurological, cardiological patients, or in any fields, it will grow on the facilities for supporting all the people, even in terms of mobile health, mobile telemedicine. Let me tell you, not only as a home care, but also in all the scenarios that the citizen is moving on.
Thank you very much. Professor Pekia?
Thank you very much. Thank you very much. And let me thank again my friend Maria Teresa Redondo for the inspiring talk. Thank you, Maria Teresa. We really appreciate that. And now, in the interest of time, if you agree, I would move to our next panelist, which is Natalie Virag. Natalie is a scientist specialized in cardiovascular disease and computer modeling. She has a master in electronic engineering and a PhD in digital signal processing. Natalie leads the cardiovascular research part of the cardiovascular research program for Medtronic. So I would like to hear Natalie's opinion about what you have been discussing so far, and in particular, if you could tell us what you think about the importance again of data in Europe. We know the data are strongly bounded to research, which in Europe is we are leading in this space, probably together with friends from the United States, but also they are fundamental in order to prepare the future intervention in terms of diagnosis and therapy in this field. If it is true in general, this is particularly true for cardiovascular disease, which is exactly your domain of expertise.
Yes.
Natalie,
thank you, Leandro, and thank you all the speakers. This is a very inspiring session. I like the question you asked, and you know, I work for a medical device company, so we talked about devices. I think Adriana mentioned the importance of devices in healthcare, and I think by having more devices, we can basically move away from treatment only to what the vision that Maria Teresa just presented, which is also prediction, prevention, and moving away from only sick patients to also healthy patients, and in a whole kind of more holistic approach to healthcare, not only looking at the patients who are sick. And the other thing we can also look at is comorbidities and try to address those. But right now, currently, I mean, as a scientist, in the company I work, we mostly have device data, but by having all these multiple sources of data coming, so either from wearables, devices, hospital data, and merging these together, we can really achieve this task. And but the challenge will be, and as a scientist, I see it every day, while I can really control device data almost, for more devices at least, having multiple sources of data is a challenge. So what was presented before on standardization will be really critical to develop new therapies. And also we'll have, therapies and prediction prevention. And we also work with different players, including non-conventional players that will come in the game. And you mentioned telecommunication is one of them. The big tech also is another, you know, they are trying to enter the game of healthcare, and many people do. So, and this is maybe a challenge to the whole team here. How are we going to handle all those challenges? And I know we have other speakers mentioning, you know, the patient point, the user interface point. But the last thing I want to say at the end of this is really the data will allow us to be patient specific. And I think this is very dear to my heart, because I think making it patient specific will make it safer, will make it much better for the patient. And in the end, this is what we are aiming for, is providing good solutions for patients and people. And I think this is a good transition to what we'll say after. I don't want to go into this, but I really think it's important to put the patient in the center, and this will be achieved by having more data.
Thank you, Natalie. Thank you very much for your comments and insightful points to this discussion. Please stay with us for this panel, and then we intend to open the floor to attendees. I see already there are a lot of good comments and questions in the chat. Allow me to invite attendees to put your question using the chat or the question and answer tool in this Zoom. Now I would leave the floor to Krishnan for continuing introducing our panelists, and then we can open a question and answer session with the panelists.
Okay, thank you. I'm really glad that Dr. Virag, you know, from industry is here. Actually, 30 years ago, when somebody asked, what is biomedical engineering? I could think of pacemaker, you know, that is easy for everybody to understand. So Medtronic has been doing a fantastic work, keep up the good work. And now, you know, talking about a pacemaker, we move to a heart, you know, that's the area of my research, cardiovascular systems. And here we have an expert, you know, Dr. Will Bourne. He is the CEO of Heart Valve Voice since 2016. It's an organization that aims to address the underdiagnosis and undertreatment of people with heart valve disease. Because a lot of people talk about ECG and the electrical thing, but you know, there's mechanical aspects, and heart valves are important, right? And he has been mostly focused in the UK. He's the chair of the Heart Valve Disease Council for Global Heart Hub. He's the founder of European Valve Disease Awareness Day. I know where to go if I need a heart valve. So let me hear your comments, Dr. Wilbo.
Thank you, and it's a pleasure to be here. I'll just point out I'm not a doctor. You would not want me to do a valve procedure on you. I promise you that. I've represented patients for a long while, but I'm not a patient or a doctor, but I've spent many years working in the valve disease space. And I think there are three key things that I would like to just get across in my kind of minute or two preamble of how we can get better access to biomedical engineering benefits of technology and therapies, and how we can take those to influence some of the European health priorities, which we know cardiovascular disease across Europe affects millions, and there are huge inequalities of accessing treatment. And those three things, I think, is about policy coordination. I think for many years, we've suffered quite a fragmented cardiovascular disease policy landscape. And while some countries have specific political and policy attention, that isn't necessarily the same across the whole of the European geography, and specifically national cardiovascular disease strategies are lacking in many places. Here in the UK, for example, we still don't have a national cardiovascular strategy. That's something I'll be taking to Westminster next month. In fact, I have a whole host of patients and clinicians calling for that action, because that will drive innovation, that will drive the appetite for biomedical engineering excellence. So we're looking for that kind of policy coordination, and particularly at Global Heart Hub, we recently launched a report and influence clinical guidelines, which will be hosted in the European Parliament next month. I think secondly, we should all be incredibly pleased with the advancements in innovation and devices and therapies for valve disease, particularly over the past 15 to 20 years specifically. We've seen new diagnostics, intelligent stethoscopes, handheld echocardiography, which is enabling us to detect and diagnose quicker, more accurately, and it can be in the place where the patient needs it. And again, that spurs on that enthusiasm from patients to get more involved in their patient pathway and ask for more from our biomedical engineers and ask more from our policymakers. We've seen minimal invasive surgeries, transcatheter therapies, again, patients wanting quicker, shorter treatments and quicker recoveries. And I think that the typical dynamics of how a patient access technology is shifting. And I think those kind of conservative-led restrictions on new devices, the health economics and commissioning barriers, I see patients and clinicians now being much more sophisticated in demonstrating the wider implications of getting innovation into the hands of clinicians and physicians. And why is that? My final comment, I guess, would be is that patients are collaborating and their thirst for knowledge is increasing, particularly in the cardiovascular space. Global Heart Hub's got some excellent examples about how partnerships between clinicians, technology providers, and patients influence change. We see now regularly on internet forums, 60-year-olds, 70-year-olds, indeed 80-year-olds asking questions about paravalvular leak rates and stroke risks based on all the products that they're available. Patients are driving forward technology. We're a much more connected community now, and that coordinated voice will drive forward technology. Patients want treatment earlier, they want it better, and they want it more, I suppose. And we're much more sophisticated, as I said, about policy engagement, making sure that that as a partnership between these excellent biomedical people across Europe, policymakers, politicians, patients, and industry, we can achieve great things.
Well, thank you very much. Cardiovascular and heart disease, look at WHO, and they always say heart disease and cancer are number 1 and 2 all over the world. So there's been a big focus even for biomedical engineers to study the cardiovascular systems. I mean, as a young student, I had a chance to listen to Dr. Christine Bernard, and also I had a chance to listen to Dr. Michael DeBakey in Houston. These are all, so many things have changed. I remember printing a heart valve like 18 years ago, and after it was 3D printed, I held in hand, it broke off. But 3D printing has advanced so much today. So research and innovation are extremely important. There are many breakthroughs which are done. So you explained things very well, and I'm glad you touched on TAVR, transcatheter aortic valve repair. This is an excellent example of engineers, biomedical engineers working with cardiac surgeons to come up with something where it improves the overall quality, overall outcomes, and also reduces the cost, the length of stay in the hospital. So in your opinion, can you comment on what are some of the other areas which do not get enough attention? And how do you think some more concrete problems of the heart valve patient can be addressed? You are an expert, so you can make some comments.
Well, I think it's already been touched on about data. I think across Europe, data on heart valve disease specifically is sparse. Too many, I think, patients receive their life-saving treatment too late. And it's a combination of that low awareness levels, misdetection, opportunities, delays, and in diagnosis. And actually, in terms of epidemiology on heart valve disease, the data is often out of date. So there's a real need across Europe to centralize databases of that data. And I think that will, again, drive not only improvements in the patient pathway leading to outcomes and experience, but also making us be more aware of how technology can be used most appropriately, as you say, to reduce to costs as well. I think the treatment choice is key. We need to put up the fact, as I mentioned, it will drive forward change with the fact that patients are asking more about what treatment is available to me. Now, obviously, I understand it clinically appropriate whether or not TAVR is available to certain patients, but actually, and I welcome ESC and EACTS putting the patient at the center of making the treatment choice, and that's really, really important, because that thirst for knowledge of patients to understand what innovative devices are available to them, to give them that shorter stay or recovery, will drive those forward. So putting more pressure on clinicians, I guess, to involve the patient. Early detection, as I've mentioned, is really driving innovation. The more there is a lot of the disease out there, and we're only capturing a small amount of that. So we need to drive early detection to then provide opportunities for more innovation to be presented to patients. And we need to tackle that through awareness raising campaigns. And then I suppose finally, someone also mentioned again about research. We need to broaden the scope of research for cardiovascular disease, particularly in valve disease, I would argue, to include valve disease, because it is one of the biggest killers across Europe. So broader research, more awareness and earlier detection, giving patients choice, and then having the data then to feed back into that kind of melting pot. That would be my areas of focus.
Excellent. I think getting patients engaged and getting them, aware of things is really important. Patient engagement, I think, brings up the overall outcome much better. And you covered these topics well. And you even said 80-year-old is asking you a question about the leak in the valve. As long as they don't ask you to solve Navier-Stokes equation or ask the Reynolds number of the blood flow around the valve, then you will be okay. I see Dr. Virag is smiling. So, Professor Picky, I pass it on to you.
I will pass it on to you as well. I will pass that question straight on to you.
Okay, thank you. Professor Picky.
Thank you very much for the very interesting discussion and conversation. I was just keeping an eye on the time because we are running a bit late. But let's go very sharp to my question for Umberto Nocco. Umberto, you have more than 20 years of experience as a clinical engineer, so really from the front line, from the hospital. And this has been a very difficult period for you and the clinical engineers all over Europe. So my question for you is how COVID has been impacting on your work and on hospitals in general from the perspective of technologies, but also how the European community of clinical engineers have been responding to this pandemic. Floor is yours. Thank you.
Thank you, Leandro. Thank you, Krishnan, for the invitation. With great pleasure for us being here today, and actually a great panel of speakers, very distinguished. So I'm really I don't feel the odd one out, luckily, because I'm a biomedical engineer. Since clinical engineering is actually an operative branch of biomedical engineering, as you might say it. So it's really being part of the business that makes us helpful in all the equation. The thing is, to answer briefly to your question, is we had really tough years. It's been really hard in the past 2 years. We've been working day and night to provide devices, trying to figure out where we can find them, even before setting them to work inside the hospitals. So it was very tiring, both for us, clinical engineering, and for biomeds who work with us every day and handle all the devices. To be truly honest, one of the things we had so far that we have to deal with in the near future is the fact that we're getting more and more technology outside the hospital. As was stated before by someone else, we have follow-ups, we have telemedicine, we are trying to keep the patient outside the hospital, which is not just a matter of having place available for let's say more endangered people, but also trying to keep healthcare working a little bit more on patients, because they may feel better if they stay at home or close to their place. So this has a drawback on us, clinical engineers and people who deal with technology, because both on the design point of view, from the design point of view, and from our healthcare management point of view, you have to keep that in mind. You have to set up devices that can be easily held by patients at their place, and that can be easily maintained and held by clinical engineering inside the hospital, who have to provide all the maintenance and all the technology management throughout the entire life cycle. More to that, of course, we need to have probably different vision and different data available to do some technology assessment. As Adriana Velasquez was saying in the first place, HTA is something very important when you have to define which technology you want to provide to the patient, and still on that side of the business, we still have to acquire data, because probably there's not too much available on all the devices that can be given to patients and sent to their house and to their places. So it's more like of working together. I mean, we're all biomedical engineers, so we need to try to work a little bit more together. Like on one side, managers and designers that tend to see the two sides from just one point of view at one time. So we need to get together and see with both eyes at the same time, like a 3D vision instead of a 2D vision, if you see what I mean. What we went to so far in the past 2 years, there was a great deal of work done by IFNBE, and particularly the CED division of IFNBE, in which the association I'm president of is part of. And we had the chance to get together, which was not so easy before COVID. I don't know why. We had a great experience in 2019 in Rome with the International Congress of Clinical Engineers, which was the last one in person. Unfortunately, this year we had the one on webinar and virtual event. But still, you have to figure out that throughout Europe there are more or less 30 national associations who collect biomedical engineers, and among these you may count up to 10 who are dedicated specific to clinical engineering. And in the past 2 years, we had the chance to hook up together, to share expertise, and to try to share our information to what we've been doing so far. One of the things that allows us to do that is that throughout Europe, we share the same regulation. I mean, we have medical device regulation and also procurement regulation that are the same, and this makes it easier, but still there are some differences. So we might need to enhance this common going together of all the biomedical and the clinical engineering movement, because and the European community can help us do that, because we need still we need some more regulation on clinical engineering and biomedical engineering without setting too many fences in which we can move in, because one of the great things that we had so far as biomedical, I think, and clinical engineering is that we didn't have too many fences. So we could broaden our view and move throughout many spaces that help us increase our professional and our contribution to the safety and to the healthcare business. So what I would say in the end, to end up my brief speech, is that we still need to work a lot more together and maybe provide occasion and chances to get together in person now that we can, of course. Although this mean that we're using today is really easy because we are all the way through Europe, and not only because, of course, there are people also from the other side of the ocean, and this is really makes it really smooth for us to get together and share expertise, which is the most important thing for everyone. Thank you.
Thank you, Umberto. Thank you very much. It's so inspiring, and I completely agree with you. We are different faces of the same medal: clinical engineer, biomedical scientist. We are all on the same boat. And all that said by you, the president of the Italian Society of Clinical Engineering, which is certainly the larger in Europe and probably one of the larger in the world. So this is particularly important. Thank you for that. Yeah, I agree on all your points. So let's work together, because otherwise we cannot face those overwhelming challenges. Now, again, in the interest of time, I would give the floor to Lutz. Then I would welcome Dr. Baller April from the WHO, because I know she has an important meeting 3:35, which actually I should join, but then we can continue with the question and answer session. Okay, so if you don't mind, after Lutz, I would give the floor to April, and then we can continue with the question and answer. Professor Krishnan, back to you to introduce our friend Lutz.
Yeah, thank you very much, first of all, for the invitation to this amazing event, Professor Krishnan and Leandro Pecchia. My name is Lutz Peschke. I'm from the Department of Communication and Design in Ankara, in Bilkent University in Ankara, and I have a PhD degree in chemistry and in media studies, and therefore my research topics and interest is especially public engagement and public understanding of science. And in fact, when Will Rowan talked about the situation that the thirst of knowledge of the society increased a lot, this is exactly what we could understand in our project as well. So I have the honor to be the coordinator of an Horizon project where Leandro and Timo Yemse are also inside. In fact, we understood especially the thirst of knowledge in pandemic crisis increased. And this has one reason. So in fact, COVID-19 is not the first pandemic, as we all know, but it is the first pandemic since the internet became mobile. And therefore, the thirst of knowledge, the information need increased a lot. And this caused a very big problem because the public, and there are lots of studies which confirm that, are afraid of fake news, of inaccurate news, but on the other side also they do not know how to separate accurate news from the fake news. Therefore, the pandemic, the COVID-19 pandemic, we can easily understand as a media crisis. But from the perspective of the thirst of knowledge, I would like to go one step further. Now, if we want to understand the role of biomedical engineering to support the EU's health policy agenda and patients in Europe, and this is in fact our the title of our panel, at that moment we have to understand the user and media perspective of knowledge transfer and innovation processes. And it means that we urgently need to include the knowledge inside of the innovation processes. No? It is not only the time is over where we can understand innovation processes as a collaboration between science, economy, and politics. It is now absolutely important and vital that we include the knowledge of the society as active partners as well. And therefore, our understanding, this is what we want to find out, is how can we do this, especially in pandemic crisis. We create in our project a knowledge platform, and also a kind of contact tracing app. And this causes, of course, problems. The first of all, we are dealing with data. We have to deal with knowledge exchange. This is what all the panelists and keynote speakers already mentioned. And we have, first of all, to understand how can we make the data transfer accurate and in a legal in a legal way that in fact it does not cause problems in the context of data protection, privacy, and so on. This is a very sensitive theme, and therefore I'm really happy to collaborate, especially with Leandro and Timo and my consortium in this question. And interestingly, it is today the halftime of our projects, and we have next week a meeting in Venice and collect all the data, and let's see what's happened. Thank you very much.
Thank you, Lutz. Thank you so very much. Before, I know Krishnan has a couple of questions for you, but before, I would like, if you don't mind, to leave the floor to Dr. Baller, April, from the World Health Organization. Dr. Baller is the leader of IPC, which stands for Infection Prevention and Control, at the World Health Emergency Program. And to be honest, if you are a lead of one unit to the World Health Emergency, while during a pandemic it starts a war, then I must say your life becomes very busy. So really, let me thank you, April, for taking some time to join us. I would waste no more time with my useless word. I would leave you to bring your comments on this panel, and then I know you have to fly. Thank you for that.
Thank you so much, Leandro, for those warm words of welcome, and thanks so much for this opportunity. I've been listening in, not for the whole session, but for part of it, and just to say it's really interesting. Also great to see some of the comments that's in the chat as well. So really just want to thank the speakers, the panelists, and MEP Tomislav Sokol. I hope I'm pronouncing that correctly, for hosting this event. And I think some of the takeaways really is the highlighting the importance of the good cooperation between experts. I've heard of many different types of experts today, the clinical engineers, the biomedical engineers, all of these experts, but particularly how they work together with policymakers, because of course we really need this joint action to have any real impact on the health systems and to make changes in the light of all of the challenges. It is very important that all of the voices of the experts, the researchers, and innovators are heard at policy level to make sure that the cost-effective health technologies that have been spoken of today, including medical devices, personal protective equipment, which is the area that IPC focuses on, and the digital health solutions can quickly reach those most needed. Very interesting discussions I heard on the telemedicine and really adapting to the situation today. So it's critical that all of these things are highlighted, but they're also brought to that next level up. And to make sure that for this to happen, that the European policies are maximally aligned with what the citizens need, steering research and innovation actions in this space. So just as a reflection of the many lessons that have been learned from COVID and looking towards the future, there's just two key points that we wanted to highlight. One is the vital importance of the international cooperation, that none of this can be done alone. We know that we're all in this together, and that has been shown particularly on the issue of vaccination coverage globally, and also being able to develop those vaccines. And one of the elements as well that's been particularly interesting has been to reflect on how prepared the different countries have been, and particularly within the context of Europe, there has been an expectation that really countries would be more prepared than they have. And I think this is something for all of us to really reflect on, and that some of the discussions today also speak to that. And in light of this, in the last few decades, the European policies have been focusing mostly on supporting innovation in the field of advanced health technologies. And this leaves some of the more cost-effective, low-hanging technologies, or the low-hanging fruits, as we say, as personal protective equipment, and also the promotion of infection prevention and control interventions, such as alcohol-based hand rub. They have been left behind. So it's really important that all of this is looked at in this light. As far as WHO has taken steps to prepare for future pandemics. And one of the key areas has been the development of the research and development blueprint forum and agenda for COVID-19. This was started back in February 2020. Within that, there was a lot of research priorities that were identified, and this has been basically followed up with over 100 different research projects that have been implemented. And as the pandemic has evolved, the group has come together again to review what are the priorities moving forward. And the last meeting was held in March, and there has been a report that has been published, and I will ask Leandro kindly to share that with everyone. And here you can read about what are some of these research priorities that are also relevant to the discussions today moving forward. And we really hope that the agenda that's being highlighted there will align with the European institutions and the international organizations to ensure that we move forward in this domain and be better prepared. So with that, Leandro, thank you for this opportunity, and back to you.
You are muted.
Okay.
You are muted.
Thank you, April. Thank you very much. Really appreciate it. I will share the link to this document and to the wider page of the Blueprint program, because it is important that all our community as a researcher and practitioner familiarize with the work that the World Health Organization have been doing, probably for the first time with this intensity in the domain of research and innovation. Once again, thank you, April, for that. Sorry to be late. I know you have to leave now, so if there is any urgent question, I will be happy to bring those to April after this meeting. Sorry for the interruption. So, Professor Krishnan, back to you, the floor. I know you had a couple of questions for Lutz, and then we can continue with the question and answer session.
Yeah, thanks a lot. I also like to thank Dr. Baller for being present. I know she's been extremely busy. I want to convey to you on behalf of the International Federation of Medical and Biological Engineering, we value your work, we respect your work, we work closely with WHO, and it is really important you are doing for the whole world. And you brought up some good points with respect to research and innovation. And of all the panelists, I think this is our goal. This is our commitment. We do this all along, but at the leadership role, the policies you're doing and the initiatives you're taking and supporting this whole healthcare field is commendable. So please continue your work. We support you and we wish you all the best, because it is for us you're working anyway. It's for all of us. So all the best to you. Thank you very much for taking the time out, and we wish you the best. Okay, thank you. So we continue with our good friend Lutz. Before I go, I want to say to our friend, the president of Italian Biomedical Engineering Society, Mr. Umberto, I work in large universities. Every time they say, who is CE? I say clinical engineer. They say, no, it's civil engineer. I say clinical engineer, because CE is clinical engineer to us. When we go to the hospital, I worked at Harvard Hospital, Mass General, and other large hospitals. Clinical engineers are really important. When things don't work, when things have to work, the health technology assessment, clinical engineering is extremely important. Just imagine a hospital without clinical engineer, it cannot work. So we are very important. Now we come to another very important person in charge of communication. I could probably say of all the people in the panel, the only person who may get a Nobel Prize is Dr. Pesky because he has a PhD in chemistry. You know, most of us have degrees in engineering. Is that correct, Dr. Virag? You know, there is no Nobel Prize for engineering, so you have the only chance. And you are an expert in communication. You know, in graduate programs that I design, you know, all the experts keep emphasizing the importance of communication. You know, your School of Communication and Design. So communication is really, really important, you know. And then there has been a great problems with this data, you know, this data, and particularly with the pandemic, you know, we need to really take good care of communicating properly and what is the perception of common citizen. Okay, so I guess you have been involved also on the projects like European Health Data Space. Okay, so please, I would, on the behalf of the audience, like to hear your comments on how do we handle with this difficult part of communication. You even brought this interesting fake news and things like that, but how do we do the good news? How do we do convey things so people have confidence in what they are listening and they can follow them?
And this is, in fact, indeed a very relevant question. First of all, our Pandovita project is especially dealing with a very, very complex question of voluntariness. Because at that moment, when we include the public, the media-based and culture-based public into the process of knowledge circulation in order to develop sustainable innovations. At that moment, we can do this only in an ethical way when the society, when the citizens do proceed this in a voluntary way. And this is especially so we analyzed a lot of COVID-19 tracking applications, especially so where less or more, we have to say less or more, the people, the citizens are involved in data collection in a voluntary way. We know in Europe there are high ethical standards, especially in anonymizing the data, in the voluntariness of using the contact tracing apps, and so on. But there are other countries and where at least the understanding of voluntariness is different, and Turkey is one of the examples. So we have there a different approach to apply to public life, like going to the university campus, going in a shopping mall. It means that we need to have a kind of so-called HES code, which in fact gives the data directly to a central database of the health ministry. And this is from the point of view from the media right in Turkey, okay, since they say this is in fact a safe database and nobody outside get these kind of data, but in fact it is not it is not voluntary, and we do not know. So as a citizens do not have the choice to understand what will happen with these data, and this is a very big problem in the process of knowledge communication, since knowledge communication is based on data. Now, and these kind of issues we can find, and this is what I hope, that we have somehow a pilot project where we can apply certain or solve certain problems which we can use in other processes, knowledge communication processes as well.
Excellent, thank you. You know, there is a lot of efforts with including artificial intelligence, data mining.
Exactly.
And then, you know, this has become really important. And engineers, you know, necessarily do not have any courses on communication. They need to learn to communicate best. You know, that is the way everything, communication is, you know, extremely important. And understanding by patients, you know, I think we have also patient experts on the panel. They brought up the topic. So, you know, I do not know, Professor Picchia, how much time we have, because we are, I think, running slightly behind schedule. So if it is okay, you know, I would like to On my personal behalf, also as the president of International Federation of Medical and Biological Engineering, express my sincere thanks and gratitude for inviting me continuously to take part in the European Parliament special interest group sessions. I think Professor Picchia deserves a great amount of credit for his initiative. You know, I think he doesn't sleep at all. You know, he's trying to go back and forth. But fantastic work, and all the panelists have done great work. I think I will pass it back to you, Professor Picchia. And once again, thanks to all. And if I'm allowed, it is right from Professor, the distinguished member of the Parliament, you know, Dr. Sokol, and everybody else, as well as yes, Lubna and our Dr. Kaliroy and Dr. Anton, everybody, you know, fantastic support work, you know, to make it really interesting and educational for all of you. Professor Picchia, back to you, please.
Thank you, Krishnan, also for your kind words. I don't need to sleep because my life is a dream, so I really don't need to stop and take a rest, no? So thank you for that.
Grant for doing sleep research and dreaming, you know, that's a good thing, new topic. You know.
Thank you. So I asked it, and we can still stay for 10 minutes if you like. So I'd like to take a few questions which are coming from the attendees, and I'm sorry that I cannot give the floor to the attendees. I know that we have many members of EAMBES as well, our elected president Eleni, which is writing in the chat, and the chair of the EAMBES for the fellows. But I'm not sure we can open the microphone. So please put your question in the chat, as many friends have already done, and we will try to answer those questions. Just regarding Lutz, 2 comments from my direct experience, especially with COVID, is not a matter. I mean, it's a matter of fact that United Nations also declared the emergency for what they called info pandemic. So together with this pandemia, we had to face an info pandemic, an exceeding number of information data such that we could not even judge its quality. So because of that, we were overwhelmed, and sometimes key relevant information was difficult to drive from the point where it was generated exactly to the point where it was needed. Some groups have done particularly well. Clinical engineers, through the leadership of Yadin David and Tom Judd, for instance, through the IFMB Clinical Engineering Division, they did a fantastic job because they had what we call in the WHO real-time, real-life systematic review. So they reviewed all the work which was coming out and brought this information to the wider community only if they considered this important, which actually is the reason why Dan Clark got this amazing prize for the work they have done, award, not a prize, from Her Majesty, because of the work that the Nottingham Trust has been doing, helping the other trusts navigating this info pandemic during the moment of huge need, which is during the onset of the first waves of this pandemic. In this regard, several contributions were given, including the humble one that we were giving with Alessia Maccaro in the domain of ethics, because it's true, there is, during a crisis, real need for responsible thinking, responsible action, but sometimes responsible silence. So we should also learn to leave the floor to really experts during a pandemic, because otherwise the good voice get lost into the noise. And this is what we have seen happening in the very start with this do-it-yourself innovation, which resulted in nothing if not overwhelming the work of clinical engineers. Because if you are a clinical engineer, you're responsible in an hospital for taking care of the technology, but suddenly you get things which are not CE market. And now, apart from working on the emergency, you have to spend extra time to assess the quality of those medical devices, those PPE, which are coming out of donation, out of the best intentions, but they are not at the quality which you can grant, and you don't have time to test piece by piece. So apart from responsible thinking, responsible action, we learned from this pandemic there is also a huge need for responsible silence and leave the floor to experts when we don't have enough experience. This is one of the lessons we learned. Now, I see many questions, and I would really like to prioritize that. For instance, Maria Teresa, there is a question from our common friends Maglaveras that I am sure you can answer better than me. Nicholas is asking, how do we think we can enable digital transformation of the hospital so that all great achievement of biomedical engineering can be implemented? And since you are leading a project which is called the Hospital of the Future, I am sure that you are more qualified than me to give an answer to Professor Maglaveras.
Okay, thank you very much, dear Leandro. And thank you, Nikos, for your question. There are a lot of different technologies that has to be implemented to get the hospital of the future. We have been working centered in some kind of aspects like the artificial intelligence, cloud computing, mobile health, wearables, telemedicine, and so forth. And of course, all those technologies have to be supporting what we call e-workers, e-robots, and e-locations. In terms of the support of the e-workers, which are all the medical staff for instance, in the hospital, this support will reduce the burden of repetitive and routine tasks so that workers can focus in making the most important decisions. So this is the best for the patients. And we are working in a project that is centered in this, strongly supported by all these technologies, basic technologies that I have been mentioned. But mainly, for instance, some kind of supports like the e-location in terms of to equip medical facilities with sensors and technologies with high connectivity, and also to be supported by that we call e-robots, for instance, which make us able to automatize logistic and material transport processes and to support in the surgical area and so forth. So there are a lot of digital technologies that will support us in this process. We have to promote the reality, really and proactive intelligent controls, for instance, in this hospital of the future. And we have been imagining humanoid robots that help us to better understand all the processes for the patients, for instance. And we have to enhance the healthcare process with tools for deep learning, for instance, and data handling and so forth. All of these are aspects in which we have to strongly work in order to build up this hospital of the future.
Thank you, Maria Teresa. Thank you very much for your sharp answer. And thank you, Nikos Maglaveras, for your smart question. Next question, I think Natalie and Will, you can both answer this question. And as you can hear, I live close to an hospital here. Because both of you can bring two interesting perspectives on this. This is coming from Olaf, one of our fellow of EAMBES and also a very experienced biomedical engineer in Europe. He asked two questions. First one is, one of the most important health issues is how to prevent people from becoming a patient. For instance, how can we as biomedical engineer promote and develop technology for prevention? Very few funding have been provided to that. Now, Will, I guess you can bring the perspective also from patient side, and especially for cardiovascular disease, but also Natalie, I know, for instance, Medtronic is to me an exemplar in that, because certainly started being very hospital-centered, but is doing a lot to get out of the hospital to work more into prevention, also for cardiovascular, but also for diabetic conditions in this case. Floor is yours. I would say Natalie first.
Yes. Well, I think it's all about showing that you can create value for the patient, both in terms of value for the patient and also improve outcome. And when you look at it at the data and examples, it is clear, there's clear value. So I think that's a short answer. I know I don't want to take all the time, but I think if you can show value, you get funding and you'll get support.
Could not agree more. So innovation is there, technology is there. What we miss is probably reimbursement instrument to enable this innovation to be brought on the primary care before patient comes to the hospital. Till the system will be still paid based on DRG, the diagnosis-related groups. That's too late. We don't want people to develop this disease. So we need to change the way in which reimbursement is done. We heard from our host MP, so-called the importance of health technology assessment. We heard from Adriana Velasquez, WHO, how important health technology assessment it is. We need to be sure that our policymaker now at national, regional level understand the value of prevention. That's technology is there. We need just the instrument to make it sustainable. Thank you very much. Will.
Yeah, I think the kind of wearable devices is something that is really exciting the patient community, and the fact that they are even here in the UK, the long-term plan, the National Health Service long-term plan talks about new technologies, wearable devices, and monitoring and taking ownership of your own health is really, really important. And I think that is a message that patients are taking on. And if you don't mind, I'd just add one thing in terms of what that question implies. The second layer to that is around patients are much more aware of follow-up treatment. So in my space, in valvular disease, patients are very much talking about, well, what about my second procedure? This first procedure, I need to make the right choices for 20 years, 30 years, or indeed 40 years ahead. So we're talking valve-in-valve technology. If I take this particular type of device, it means I might be on warfarin for the rest of my life. My preference to avoid that is to take a technology that perhaps is not necessarily, we have the data for longevity of certain devices, but that's a risk I will take. I want to take that. I will trust in the technology. So I think, again, that there's a real kind of that prevention. Also, there's an issue around picking therapies that actually have the flexibility and the technology in there for the future is very important to patients.
Thank you.
I have a short comment. Can I make?
You are
a great question by our good friend Olaf. We talk for biomedical engineers always diagnosis, treatment, rehabilitation, treatment planning, and all that. But prevention is an important part. Okay, and when I was at Mass General, Harvard Hospital, we had a program called Be Fit. So making people aware of staying fit, eating right, exercising. And that's where biomedical engineers come into play, is start designing devices for this. And it is already taking place. Look at all the gyms and exercise work going on. And when you have prevention in the spectrum of biomedical engineers, the market size becomes very big. Everybody needs to prevent. It is not only the sick and diseased, everybody. So I think for us, it is really a very bright future. Of course, it means we will all be living, I'm sure Leandro will live more than 150. So then we live longer years, and we need to plan for, what is happening. But in seriousness, the life expectancy is increasing. And so prevention is an important part. And I think we need to start introducing it right in biomedical engineering curriculum, and then also encourage people to design devices in their projects and so on. And it is actually becoming reality. And as I said earlier, the market size is big. When there is money, people will get funding for it. So prevention is important.
Thank you. Thank you very much, Krishna. There is another question that I really like, where I think, Umberto, I'd like to hear your opinion on that. This is from Professor Cerutti, which is not a question, but it's rather an important comment. And let me say hello to Sergio, which is also a very good friend. Sergio is asking how important it is, this discussion, also for medical students. And I think for you, Umberto, you work every day in the hospital setting. So the way I would phrase this question for you, it is how it is important to increase medical doctor knowledge of technology to be sure that together we can do more.
That's a very nice question. As far as I'm concerned, I think that's strategic. you need to have you need to have a new generation of doctors, if you see what I mean, meaning that they need to understand technology, and they need to have the same data sets and items that we usually need to evaluate technology, so we can talk the same language. We've been speaking a lot about HTA as a bridge between scientists and decision makers. Probably it's the time to just keep the two coasts close together. I mean, we need to talk the same language, not finding someone who tries to do the real-time translator between the two, and providing doctors with some technology knowledge, basic technology knowledge. Probably that's one of the issues. I'm not very fond of some experiments that have been going through in Italy regarding kind of merging medicine and engineering in the same faculty and in the same process of studying, because they're really two different sets of knowledge and two different points of view to some extent. But still, you need some the English word doesn't come to my mind, some convergence to that. To some extent, in my experience, what we've been doing in Milan, in Politecnico di Milan, some years ago when I studied engineering, it was that we went to School of Medicine to learn physiology and some typically medical subjects. I've never seen engineers go to medicine to teach engineering subjects, and the way we look at technology, probably we've come to a point when you need that, because being data, being ICT, being specific technology, we were talking about heart valves, but also we can talk about pacemakers and everything else. I mean, I was looking. I'm a Ferrari fan, of course, but we were looking at the Grand Prix on Sunday. If you don't understand the car, probably you would never get the chance to drive it that fast, and the way the good drivers do that. So that's the same thing for physicians.
Yeah, thank you. Clearly, this does not apply to football, but
no way.
No, but curling, we are getting better. So I agree with you, Umberto, and I agree with you that there is a huge need, and there are now many programs, I must say, also in Italy, where there is more technology taught to medical students. So I come back, last week I was in Pavia, where there is a new program where I gave a module on medical devices to medical doctor students, and similar program is starting at University Campus Biomedical Rome, which I joined last 1st of February. So more and more is coming, obviously with different mindset, with different needs, as you said, but I must say I'm positive also in that, as you are and as Sergio is, because more is coming. There is now clear understanding from both sides that as we go, as you said, very effective, as we go there, learning physiology and anatomy, they are coming also to learn more technology. So this is really an exciting period. And now, Lutz, last question is for you. And one of the panelists, I think again, Olaf, was asking, what can we really do in order to facilitate the introduction of innovative solutions in the healthcare space? And the question is for you, because I think the bottleneck is also in the lack of understanding that often we have of the other important domains, which are essential for the successful introduction of technologies in healthcare. Floor is yours.
Yeah, thank you. In fact, the approach of our Pandevita project gives at least a suggestion for a solution. In fact, what we want to create is a knowledge platform where, in fact, every expert, but also the citizens understood in certain cases as expert can contribute with their knowledge. And at that moment we have in fact information which people not only can get from a platform but also contribute, because the knowledge exchange is a communicative process, and this in fact creates on the one hand side trust. Of course, the prerequisite is that that these kind of knowledge which is or data which are inside the platform are somehow evaluated. But on the other side, it also creates activities, and this is, according to me, what we need. It is very difficult to when we limit the media-based society only on receiving knowledge. At that moment, we have a problem because at that moment we have an inactive citizens, and this creates the problem that they are very open for every kind of platforms, and the one who are describing certain topics very let's say attractive are sometimes more believed than the evidence-based information. And this is in fact what our approach is in Pandovita, and we are now checking in which way we can motivate increase the voluntary participation in these kind of knowledge processes.
Thank you, Lutz. Thank you very much. In the interest of time, we have to go towards the closure. There is another question from Nikos Maglaveras, which I'm happy to answer. Nikos says here in the question and answer tool is one of the goals of EAMBES since 2003 was to establish a dedicated. Was this achieved? Was not achieved. If I can do some constructive criticism, the question was ill-posed. We cannot pretend to have a biomedical engineering panel into the ERC if we first don't understand well how the European institution works. We realized that in order to get a panel into the ERC, and there will be many other institutions, the first thing we had to do was to get biomedical engineering officially recognized as a discipline and profession by the European Commission. There is a database listing all the profession, skills, and field which are officially recognized by the European Commission and therefore European institutions. So we worked with the European Parliament, as we are doing today, since 2016. We achieved this goal with 2 parliamentary questions filed by my friends Nicola Caputo and Lara Comi, former MPs. And together we asked to the Commission, A, why biomedical engineering is not there? This was then accepted because clearly there is no objection. We are a relevant part of the healthcare system. We are now in this list, therefore there is biomedical engineering among the list of skill and profession of the European database of skill and professions. We are now working together with the World Health Organization to achieve the same results with ILO, International Labour Organization, but we achieved this goal too late for getting then a new panel for the Horizon Europe. So we got this great result. It was 2019, I guess. It was too close to the launch and the organization of the new Europe, Horizon Europe. So I am sure that working together in this direction, we can do better, and probably for the next program, you will find a dedicated panel on biomedical engineering. Things have not been holding. I mean, we have got several biomedical engineers chairing relevant panels of the ERC. I can mention Nikita from Athena. I can mention common friend such as Professor Fotiadis from Ioannina. I can mention Paolo Netti from my alma mater in Napoli, as chair of one of the panel of bioengineering. So things are getting there. We need also to learn how to phrase properly questions if we want to get answer from the European institution. And in this case, we have been learning and doing better and better. I see tons of very exciting questions, but we are 40 minutes late, and I am afraid we cannot take more time from the panelists, from the speakers, and from the organizer of this event. So let me close this now today, thanking again Mr. Sokol for the great opportunity he gave us to bring this discussion to the European Parliament. He had to leave, but I know that people from his staff are here. We will take notes from this discussion and present him as a possible consideration for action points for future. I commit myself to organize further meetings as the one we are having today, possibly in person in Brussels, but still open so that we can get huge participation as we did today. We arrived to more than hundreds of attendees. So let me thank all of you. First of all, Professor Krishnan for accepting the invitation to co-chair this event with me, Timo and the EAMBES for supporting this idea, all the panelists for taking this time, particularly for the World Organization friends. As I said before, if we get a war during a pandemic, this can be very tough. And our colleagues at the World Health Organization, they're really working 20 plus hours per day to face these emergencies. So let me thank all of you.
Can you ask the other people to come show their beautiful faces so we can take a picture of all who are there now? I see Lubna and Kelly Roy, you know.
Yes, that's the speaker view. So the attendees, they cannot see, but the speakers, they can. So we can do that now.
Possible.
Thank you.
Kelly Roy, yes, smile.
Okay, but the speakers, they cannot see this view. They only see once per time. So let me thank also the attendees, because they also took up to 2 hours and there are still few which are joined with us. I saved the chat and the question. We'll try to answer at least in the proper section of the EAMBES website as soon as possible. This webinar has been recorded, will be put on the YouTube channel. And again, you will find there further links as the one that Adriana and April Baller suggested. And we can continue this discussion over there. There is space for question and answer also in those channels. Thank you so much.
Oh, thank you.
Bye.
Thank you.
Bye-bye.
Thank you very much,
everyone.